Start this session now. I think the title was Government Reporting or Reporting to the Ministry of Health. So perhaps I can just ask you, does anybody have any thoughts on the format for the session? Should we do a fishbowl or some other format? Any thoughts?
I'm going through the concession.
Vote of confidence.
Not because I don't like this one. I want to be here too.
You choose. Okay, does anyone have any input into the topics that we should cover? Does anyone want to voice an opinion on what they mean?
So MPP, as I mentioned earlier, has an initial requirement, which would be just to be able to report to the Ministry of Health from our primary care clinics on a regular basis. So that would definitely want to cover that. But the other thing that we haven't really mentioned this time, but we have mentioned in prior implementers meetings, is that we actually also have the desire of creating a centralized data warehouse with anonymized patient data. So at some point, this notion of creating a warehouse, either at the national level, which might be appropriate to this MOH discussion, but also maybe even at the supranational level, I'd like to address those or have those added to the agenda.
Sorry, so that was data warehouse.
Data warehouse.
So, assuming that you're building a system for electronic reporting that has as the aim to replace a fully paper-based reporting chain, how are you going to go through a process of having your reporting tool audited and explaining the differences between the paper reports and the electronic reports? Because there will be differences, and typically the burden of proof will be on the person building the electronic reporting tool to explain the differences away. So this is a very relevant problem for us.
Okay, any other inputs for discussion? So at the back there?
How we can engage the government agencies who are talking of the national level, how to engage them so that they end up to use the data for different decision issues.
Sorry, was that how we can engage with the various government departments to use data for decision making?
Because we are talking about the national reporting, so
right.
There's something to do with it at the national level, at the ministry. So how do we bring them on board?
Okay. I'm going to add one here, which is harmonizing reporting systems. And sorry, I didn't appoint a rapporteur. There's somebody who's willing to take notes from this session. Thanks, John. Yeah.
Maybe something around who owns this information and who owns the data. Is it the ministry? Is it the hospital?
Emphasis on the importance of local data collection and use, not just the collection of data for national reporting.
So does that have to do with feedback systems or getting data vertical, flowing upwards and then flowing back again?
Well, feedback so that people can use the data locally rather than that situation, the things I like to call the systems that only suck, to pull all the data into the center.
All right.
But also, I mean, it's a way of validating the quality of the data.
Great. Okay, are there any other issues or points that people would like to have discussed? I mean, coming into this meeting, was this what you thought we would be talking about, or are there other things? Carola?
I was expecting some perspective of the citizen perspective within the country. It does, as an OpenMRS capture basically health status, but I'm really interested from a national point of view, the accountability towards the citizenship.
Accountability towards the citizen. Okay,
Yeah.
what else?
Hi Chris, I'm here.
Oh,
I've done a lot of work for HISP, sort of district level with district level managers, and I think we need to remember that there are lots of levels of information use, right? So, I mean, it has already been mentioned that there's local needs, and there are many needs sort of on the way up to national level. So even though the reporting formats might have been decided by the national, there are managers at district level and facility level that needs the same information, right?
Right.
So interaction with local managers that needs aggregated data or service-based data for decision making.
Thanks. Eva?
The clarification of the report. Clarification for the reporting indicator definitions. For example, like a lot of the time they will ask about how many initial visits or how many return visits per month, and then by 2 columns. And am I supposed to go to do like double counting, one of each? Or, but then they have like a total number on the 3rd column. So when you add all of them together, as if like we overestimate.
Mm-hmm.
Yeah.
So it's indicator definitions. Okay, should we take one more, if there's? All right. Okay, so we're going to start off with data warehouse. Andy, was that you that proposed that particular topic? Do you want to start us off?
So for the notion of a data warehouse, I think probably people think of it in different ways. So there's both the notion that a data warehouse is just one central place where you put the data and you have like a master copy of OpenMRS or something where everyone can access it. Or you can think of it as a structure to serve many other purposes or secondary uses of that data. So when we had first thought about data warehousing and reporting, we thought, well, maybe we could just create one big OpenMRS system that, since we all had a common data dictionary. But we quickly realized that the OpenMRS data model isn't really very good for supporting large volumes of data, particularly from different disparate sites. And so one of the things that we wanted to be able to do is to automate some sort of a process where data would be extracted out of OpenMRS and be then aggregated into the data warehouse. And what's slightly different about the Ministry of Health sort of data warehouse versus what MVP is particularly interested in is that usually the ministries only receive aggregate data, summary information, and that they then combine that summary information from various sites, a la the DHIS system or something, to do their work. But what we would really like to do is actually have the patient level or the actual row level data brought together from all the different sites. Now, one of the things that in the health metric work has identified in their framework is that typically as you move up in a system of aggregating data or higher and higher orders of combining data, you get fewer and fewer data elements. Just in general, for practicality's sake, it's much harder. But I'd like to try to counter that as much as possible by saying how much can we keep the individual data in a data warehouse in as far along the process, but maybe stage how much of the data comes through at any given time. So like issues for us then would be, where do we put it? Like, it's not going to be an OpenMRS database. It's presumably going to be some other kind of database that the data goes into. Two, what are the processes for getting things out of OpenMRS and into that database? Is there a way to automate that extract process? Three, is there some kind of informed consent, or does there have to be some sort of documentation within OpenMRS as to which patients can be allowed to be part of this? And you know, what kind of triggers are there in the database to either allow or disallow that kind of data? And then what are the elements do we want to collect? And you know, is it the entire OBS table that gets somehow transformed into something else, or are there subsets of data that would then aggregate up? And then the last thing, which sort of out of this, we want to be able to certainly, you know, generate the MOH reports, and so those maybe 15, 20 indicators that are necessary for ministry, we would certainly want. But we'd also want to look at then what's the next step would be analytical tools for data mining and so on, and really to sort of, you know, what are the ways that we could then attach to this database using things like SNOMED maps or things like that to really let us you know, find things within the system that we wouldn't have normally done. So for example, the work we did in South Africa in '95, we created essentially a data warehouse from the HIV clinics in from Johannesburg General Hospital, New Somerset and Cape Town, and we looked at some classification tree analysis. We looked at some data mining on that technique, or on that database, and we found that HIV patients in South Africa who had supplemented with vitamin B actually had much delayed progress to AIDS, and this later became, you know, a big deal. It was, you know, prospectively proven. So this ability for us to capture this real, you know, patient-level data from a real-life situation in a large data warehouse that can be analyzed for research purposes as well as reporting to the ministry, I think is where the options, where the most opportunity lies.
Thanks, Andy. Okay.
I think that's really a very important point, Andy. I would say, speaking personally, that we tended to shy away from trying to actually export all of the patient records because there are a whole bunch of issues around ownership and confidentiality that I don't think have really been broadly addressed in a lot of countries. And I'm really interested in this, maybe a good venue for people to talk about what they feel about that. Is it the best way to have all of the patient-level data analyzed at government level, or is it better to keep more of the analysis nearer to the sites where patients are being managed and cared for?
Okay, any other comments on that topic? I'll start off just by talking about this issue of aggregating the data, and I'd love to hear what Ola and Barbara can respond to that. We built an application called Electronic TB Register in South Africa, which takes basically TB data, it's stored as patient-level data off a TB register, and then is compiled into a district register by the TB coordinators at district level, and then from there it is exported up to national level. But at all stages, in fact, although you can only see the data in aggregated, de-identified, anonymized format at the higher levels, in fact, the patient data is still within the system. So you can still build a system like that, which has got a view, and ETR.net has been distributed and implemented very widely within South Africa and a number of African countries. So that's one architecture that you can use where it's still in there and the data is within the view. So how do you, I mean, with the DHIS, you follow a different philosophy of anonymizing and aggregating the data right up front. Do you have any thoughts on that?
So in the system you're describing, Chris, you keep the electronic medical records, is that what you're saying? You keep data at patient level as it goes up?
It's not a strict electronic medical record, it's really just, I don't know if you've seen the normal TB register, it's got a name and
Okay.
some basic demographic data. So it is identified as a sort of basic.
Sure. I think one important issue is that if you're looking at the whole primary health care and not one program, what is sort of the realistic scenario for collecting data across all your facilities? For immunization data, for all kinds of, maternal health data, delivery data, antenatal care, and for the district level to really capture all that data and be able to do analysis on their whole population. Is it realistic that you can actually capture that on patient level? Do you have computers at all these clinics to actually do that? And I think that's where DHIS comes in, that when you don't have that option, you can, for the district manager, it's important to have full coverage of the population, right? So that they know they can get service data from all the facilities aggregated through this aggregated reporting system. And when you have computers at facility and you have OpenMRS or other systems, then you can go in at that detailed level. But sort of by TB patients, that would be a small sort of part of the population, right? But when you want to cover the whole primary health care aspect, can you do it the same way, or? I guess that's the question. And for district manager, obviously they need all the facilities data. And then, at least in the countries I've been in, then it's a real challenge. Can you actually implement an OpenMRS in all these facilities, or do medical records electronically in all these facilities? I think you can do it in a sort of stepwise manner, but these systems need to live together, and I think you would need aggregate systems for a long time ahead of us in order to have that data coverage at district or at province or national level. Yeah?
Yeah, definitely.
I would love to hear from, I heard you mention yesterday that people are talking about moving to more primary health care. What are sort of the experiences you have in collecting data across all programs, not only TB or HIV data?
Balancing correctly the need to get data with the need to protect the information from unwarranted use is tricky. And clearly, I think you want in every case to report up the minimum amount of data necessary to answer the questions. But for diseases that are both kind of problematic from a stigma perspective and also long-term and longitudinal, it's hard to know how you, like HIV, it's hard to know how you're going to be able to follow the health of a population without having some individual patient level data at some level above the facility as people move across facilities. Now, de-identifying those data in some way that is still linkable but not obvious is probably the sort of best solution. And then you may not need it at a national level, but you might need it at a district or at a provincial level, depending on what the migration patterns are. But these are going to be different for each question you want to ask. So this is quite a complicated endeavor, and I actually think it's necessary in order to know what's happening with HIV that we begin to introduce the idea that we will have to collect non-aggregated data in some level.
Yeah, I think Ola said it when he said that we're going to need both systems for some time to come. And I certainly know in South Africa the history was, which I think the general consensus is this was a good approach, was it aggregated, the DHIS was rolled out as the initial public health system, and then slowly now trying to introduce electronic medical records. So I think that reflects the priorities.
I was late to the conversation, so I didn't hear what provoked your initial feedback, but the standard of care, at least in places like the United States, has always been that when you have patient-level information, that those data usually are the kind of the responsibility of that healthcare facility, and they're responsible for maintaining the privacy and security of that information. There are certain cases where you might need to dive deeply into account to understand how you arrived at that number, but you should probably have to justify that before you get access to it. I mean, I think that that would be the standard that at least I know of. And so to me, a design where you're thinking about working from patient-level data up to these types of data warehousing solutions, I've always envisioned them being that the default behavior of a facility would be to pass the aggregated data, the statistics, but in addition, have some way to reference back to those individual patient-level records, but not actually pass those records. So what you don't get from aggregate numbers, you don't get what's underneath that, but you should probably have to justify that you actually need that, and we need to look at this because of this reason, and then a separate transaction goes and gets the detailed information that you need. But I mean, a model in where all patient-level records are held at kind of this data warehousing level is not really a standard that I know of in any place, really. In fact, if you talk to a hospital or a clinic in the U.S., that would never happen. That would never happen. So we're not talking about that here, are we? Because that's not realistic. That's my opinion.
Well, again, just coming back to the South African model, what we did, I mean, I think where it was useful, I don't know if you were here when I explained the system we have there, this TB register. And I mean, again, as Ola is pointing out, TB is a certain case where the actual patient data is carried within the warehouse up to the level, and all you see is aggregated view on top of that. So you can, in fact, drill down into patients. And where that was particularly useful was because we started that ETR project many years before AIDS became really something which was being treated in South Africa. And when we started on the ART system, several papers have been published now on linking HIV to TB, which would only have been possible with that patient record. So it was for those kind of things, and I think where you evolve from a reporting system to something where you're trying to do research on the application, it's kind of, I think as Zen is saying, a bit of a tension in the beginning. You need to understand how much effort you're going to put into patient-based systems versus aggregates. That's why I think South Africa, it was an appropriate thing that the HISP did in terms of rolling out aggregated systems, and then we started coming with the patient-level data, and now we're trying to integrate that. So to me, that seemed like a sensible roadmap. I think my question really is around where the DHIS is right now, is that seems to be kind of, when I think about using the DHIS in Mozambique, for example, it's kind of something which is side by side with a data warehouse project. Would you say that? Do you think it replaces a data warehouse, or is it a separate thing?
Do you have a microphone? First, let me comment on what Paul said also. Can you hear me? Yeah. I think, first of all, I don't like the notion of reporting system, right? Because I think if it's something DHIS is all about, it's management, right? So it's management data. So my point was that at the district level, the important thing for a manager would be to have full coverage of his population, like all the health services. And if you want that, I think in many districts, you can't do that by having electronic medical record system. It's not realistic. It's not sustainable. I mean, hopefully we will be there one day, huh? But I mean, what we've seen with the DHIS implementation is that that's a way to get that coverage so that the managers can make decisions based on data from all their facilities, huh? And that has to be on paper in order to get that coverage. But I mean, slowly that can move towards electronic data reporting, but I mean, we're not there yet. But I think that's why I said this can live side by side.
The distinction I was making, so everything that you said is important and right, exactly what should happen.
Just let me comment on the data.
Okay, well, let's do the microphone now.
Okay.
Need a microphone.
I just wanted to quickly say, everything that you said, that's exactly what should happen with these data, right? But it's an issue of architecture. It's like, where do those data live, right? So, being able to get down to patient-level information has immense value, but if you can architect it in a way where those patient-level data live in something other than the warehouse, but there's a reference point in the warehouse to those data, and the proper privileges and privacy and confidentiality issues, they're much easier to deal with when the people that are collecting the data are making sure that the data is kept confidential. So I don't disagree with what you're saying. I don't want you to misunderstand me. I think you need to do it, but an architecture will let you have your cake and eat it too.
Just Paul, to your earlier point, I mean, the creation of patient-level data sets is not new. I mean, we don't call it data warehousing necessarily, but in fact, public health surveillance is exactly about building cohorts of data for public health purpose, and they are explicitly legally authorized because there is a justifiable public health rationale for collecting them. Now, you know, how do you sort of facilitate that in this context is sort of a different question, but you know, in the U.S. surveillance system for HIV, pays public health workers to go out and extract data from data sets and create a surveillance data set that can be duplicated across patients, because aggregate data can't do that.
So the one concern I think I have just in this last discussion is that we seem to be conflating two particular issues. There's the issue about patient data, patient-level data, and then there's identified patient-level data that's actually needed. I mean, I think everyone would argue that at the clinical setting, people obviously need to know who the patients are and be able to run analytics and figure out, you know, which patients need to be seen and have actual identifiers. But that as you move up this path, you need row-level data or patient-level anonymized data, which are similar to the public health data. And then above that, you have the aggregated numbers. And I think for Olaf's point, I mean, there's always going to be a separate group of people that are always going to come up to the aggregated line, but that it cannot replace this sort of, either for public health reasons or for the potential for just quality improvements in healthcare. We need patient-level data above the individual clinic. And so I would just argue that we would really think about that confidentiality and anonymization process so that we could move the data up with some confidence. It may not be everything, but it would be a lot of things, and certainly more than the aggregated numbers.
I'm just going to take the opportunity as I got the microphone. I think that in addition to these important issues is the fact that you need to have some way of validating the quality of the data. And if you don't hold individual records on the patients at a facility, it's extremely difficult to know whether the data you're getting at higher levels is in fact accurate or even based on any real patients. And we've seen this problem very widely, where there isn't a record and there isn't a process in place where at least some percentage of the records are validated, and you can go back to the original site and say, do these patients exist, and you know, is this a realistic and accurate assessment of what's going on? So whether that data is kept as an individual record level, and it could be paper records, but they need to be well designed so that they can be computerized and sampled in appropriate ways. That, I think, is the minimum you need, because without that, you just really can't believe the numbers. Now, be able to propagate some part of that record, maybe de-identified further up the tree, may be a very valuable thing, but obviously within the process that we've looked at it, the concerns about confidentiality and ownership.
Okay, thanks, Hamish. Are there any other points on data warehousing? We've got 15 minutes left, and we've got a couple of other topics. Paul, did you want to make a comment?
I could go on forever.
Yeah. That's the problem. Okay, data validation. Hamish?
Yeah, I just wanted to make one other comment that we have to remember that there are other tools which collect data in the private healthcare facilities. So while thinking about data warehouse, we have to think about all the other different data sources, because we have a lot of data that we need in the warehouse that it may not necessarily be collected by an EMR.
Richard, could you give some examples?
Yeah, for example, we have data on HR, for example, HR data, we have, which may not necessarily be collected on EMR. We have some data on medicines, stock levels and so on, which I think some EMRs do capture, but some may not necessarily capture. So there are various or facilities or medical equipment which is also necessary in data warehouse, which may not be necessarily collected. Maybe just comment on the point which has been discussed of individual data records being available beyond the healthcare facility. I think it's more of a policy issue than anything, because the issue we found in Rwanda, for example, that we don't have that clear policy of who has access to which data. So once that is very well designed, I guess there may not necessarily be a need for individual data records to be available at a higher level, but when required, if there's any need to dig deep and find out if the numbers are correct, then there should be a certain policy that's defining that. Thank you.
Right, thanks very much, Richard. The next topic that was listed is data validation. Could the person who proposed that start us off?
That was really neat. Yeah.
Okay.
You won the prize. Great. It's not just about data validation. It's really about it's about how do you convince the Ministry of Health that what you're doing is what they want. It sounds very simple, but it's actually not that straightforward. Certainly not some of the places where we work. Certainly there's a data validation that you want to do on everything that you can in terms of improving your own data quality. But I'm mostly interested to see what other folks have gone through for an audit process. We went through an audit process, and it actually takes a long time. And it, in the end, it has signatures and all kinds of good stuff. But that process seemed way too painful to me. So I'm mostly interested to see what other people have done in this area.
I mean, I can tell you that so we send reports on patient. We send reports from inferences from patient level data at AMPATH in Eldoret, and they questioned some of our reports early on, and so what we did is we sent the recipe to them. We say to them, here's how we arrived at this indicator. Here's the algorithm that we use to infer that. If you have a better suggestion, then let us know. Basically, here are the keys to the kingdom. Here's how we did it. If we can do it better, tell us how. I mean, because I don't know if you're like we are. I mean, we feel like we do the best we can, right? We're not even totally confident that it's exactly right? So, yeah.
I think another thing that we're pushing for in South Africa is a national data dictionary and indicator repository. We have some of these pieces already, and validated and well-defined algorithms for calculating these indicators and where the data is stored, repositories. So we have a project, the EHR.za project in South Africa, which is hopefully going to precipitate some of those actions.
Yeah. There's something we've done in Kenya which is, and I must agree with the other guys who say that this is a painful process, but necessary, painful but necessary. We've got this DQA, data quality assessment tools, or data quality audit tools, that what we do is we look at data over a period. So if, for example, we're looking at clinical data on, let's say, how many new patients we're enrolling on treatment, and we kind of sample facilities, get a fairly representative sample in terms of various types of facilities, provincial, district, level hospitals, and then lower level dispensaries and health centers. And I mean, come up with a sample that's pretty representative, and then go down, and this is done through the Ministry of Health staff, so it's not like it's the partners of CDC doing it, but it's really the Ministry of Health. And then go down to the source documents. The reason I say it's painful is because you really have to go down like to the patient reports, the patient cards, and just kind of look through a period. If you take like a 3-month period that you're auditing, then you have to go through literally every record for that period. So it's really painful, but and it takes a couple of days, but in the end, it gives you a very good picture of the quality of data that you're getting at higher level. So we've done it, it's worked. We've covered, I think, about 20 or 30% of the country, but the results have been very good. And we have a feedback mechanism, so it goes back. The information is just not for, just like for feeding up to the national level, but also it goes back to the health facilities in terms of improving quality of care and improving quality of the way data is collected, and yeah, just having a clear two-way understanding of the validation process.
I'm sorry. What have we done in I give you the two experience really. Australia, for the validation, we do it at the clinical level through a clinical governance framework. They are clinicians who actually validate the data, especially mortality and morbidity data. For the errors in medications, they are defined quality indicators. They do the validity of the data. Then it goes to the next layers within the ministry is a quality branch. Therefore, they got a data management strategy, which they got some tools that you can actually query to the IT part of it, which I'm located physically, is the ICT strategy. We do SQL queries, we go to report, but from a health ministry point of view, it's very political. The factors that drive the validity of data is depending how many times we are in the media. And that's important to us to have an ongoing quality revision and monitoring, because usually if your surgery went wrong or medication errors went wrong and goes to the media, we have to provide those documentation.
I just make one quick comment, because I know you want to get to the next thing, but I think it's just very important to set the expectations correct with this the ministry, because I think the other thing that Eric was mentioning is that sometimes they don't want to know this information. I think Chris has lots of examples of this, but oftentimes we provide bad news because the data that they've been collecting has been manipulated to make it look good. When they actually get the real data, it looks bad. Just be prepared.
In Ghana, for example, you always find out that the normal data which is available is the aggregated data. So the actual validation is actually it's not so easy saying that you are validating the data, because what is available is an aggregated data. So in a way, you are not actually getting even the patient data to validate it. So I think what we're doing now is that we originally had patient data entered in CS Pro, and now that we switching on to OpenMRS, this is where we can actually validate the data.
So when you say you're switching to OpenMRS, is that moving down to a patient level of collecting data? Because you mentioned aggregate data up front.
Yes, what I mean is that with the MOH, the Ministry of Health, per se, the data exists only in aggregated form. But for now, as we embarked on patient data using, say, CS Pro, and we just want to validate the CS Pro event, which is a patient data.
Okay, thanks. Can we move on to the next topic here now, bringing ministries on board?
We had a whole session.
What was that? There's a whole session on that. Okay. Harmonizing reporting systems. Okay, I raised that one. I mean, what the situation that we have is often being asked to, pardon me, furnish reports for multiple different sources. So there's the Ministry of Health indicator reports, there's the PEPFAR indicator reports, Global Fund, etc., etc. So we're working on strategies to try and harmonize those, which involves a concept dictionary of harmonized terms. And then try and also bring the same thing to the aggregates, the indicators. So that's kind of, I guess, a problem that we have in South Africa that we're working on, and interested to know if others have that and the strategies that they're using.
Actually, I think maybe Evelyn can help me because she does the reports, most of the reports. We encounter similar problem because we report like similar indicators to different reporting agencies, and sometimes they use different definitions. And when when the head of the program try to cross-reference all the reports, why this PMTC program you say you have X number of, you serve X number of these pregnant women, but then the other one you say X plus Y. So it comes down to like very difficult for us to explain why the number on report A is different from the report B, even though we're answering the same question, just because they require different definitions for the indicators.
I actually would like to hear the DHIS kind of response to this, because it's one of the issues, I guess, of building indicators is that once you've got aggregated data, you can't create new aggregated data from those. You have to go back to the primary. How do you handle the fact that there's changing indicators or definitions change?
I'm not sure I got sort of the essence of that, Andy, but if you look at the aggregated data sets that are being collected at facility level, I'm always a bit confused when we talk about indicators and data elements, because as you know, in DHIS, an indicator is a calculated indicator that has a numerator and denominator, right? So it gives you a percentage or a rate. But when you mean indicator, you also mean sort of raw aggregated data, like number of clients?
So it works either way. Let's say that for one report, you need to have this numerator with this denominator, and then in another report that wants the same information, they define the numerator differently. So you actually would have to go back to the raw data and calculate it differently. So I guess that's right. You import aggregated data from the very beginning. So
the raw data is
in a new model, when you have OpenMRS connected to DHIS, how do you think that this would work to create multiple definitions or handle different definitions for the same kinds of indicators?
I think one important thing is that when you have a data dictionary, as you talk about, Chris, at the ministry in South Africa, what is important is that even those they would be sort of aggregated elements, and then but what you need is in addition to that, I think you need sort of instructions how to calculate that based on patient level data. I think that's really important, so that you agree on how you get to that number. I mean, what's the procedure you use to calculate that? And it's also, as you said earlier, that they question your data and you have to send them. Paul said they're sending the procedures how to calculate it. I think that's an important part of the definitions, right? Adding to that quickly, I think his working in countries has the norm. I mean, when you're up to sort of the hierarchy, you work closer with sort of the management levels, and you have to work closer with the ministry. So we are often sitting at sort of data revision meetings with the ministries, defining these indicators together with different program people and district people. So HISP never comes with their own sets of indicators, right? We are representing then the ministry and the district level managers. So I guess it's a bit different. Yeah.
Okay, any other points on that issue?
If OpenMRS comes with a standard reporting, and the standard reporting might not be what, say, MOH may require, in any case, we might not be able to satisfy all our customers. So there should definitely be a way to export anonymized data, so that we might be in a position to process that data to meet other demands.
Thank you. Any other points?
Just a quick follow-up. Isn't that possible now? I understand you can sort of calculate any aggregated number you want using a flexible reporting module, right? Don't you do that? I thought that was the idea. This one we discussed.
That's the 4:30 session.
Well, till 4:30, yeah.
If you're storing the data and if it's in the right atomic elements are in the right definitions, etc. I mean that's something that we're struggling with at the moment, is that you know, you get multiple definitions of atomic variables on forms. So people commonly don't start off with a concept dictionary or some kind of ontology. They start off with taking forms, transcribing them, and then, you know, the kind of ad hoc way that these things are labeled, they use that to derive an atomic data element. And when you're trying to integrate that data or aggregate it, etc., well, you're not totally sure what they meant.
Just to comment briefly on the reporting side of things. So with the new reporting framework, it is possible to sort of export a variety of different types of data sets that you might need. Those data sets may be indicator-based data sets, which do the pre-aggregation for you based on calculations you've defined in the system, and they output a data set that just is basically a question and a numeric answer. On the other hand, we also have data sets like today's sort of data exports, which allow you to export a table of data, actual patient columns with rows, and you could do that in a de-identified manner if you so chose. So there are a lot of flexible options around the new reporting framework that allow you to get out of the system the data that you want. Along the lines of indicators, what we're calling indicators anyway, maybe we'll change our terminology now. Data elements. So there's a notion now in the new reporting framework of being able to define an indicator configurably within the system, and you could create more than one indicator potentially that represents the same, I guess, thing you're trying to represent, potentially with a different calculation behind it for a different reporting agency. So if you needed to do that, you could so choose. There's also a separation between what an indicator is and what it looks like on a report. So for example, you could define an indicator here. When you actually add it to a particular report or a particular data set, you give it a sort of display name and various ways by which you can refer to it, but it's the same indicator calculation under the same. So there are a variety of different ways to do it. As long as I have the mic. Also point out that in some of our current systems, and not all OpenMRS-based systems, but we have, the way we report to the Ministry of Health is that we, and other reporting agencies, that some of our data is aggregated based on actual patient records, but not all the data that we're required to report on is captured at the patient level. So we have a system for both calculating indicators based on patient data, as well as allowing data clerks to enter sort of facility level data that's pre-aggregated before entered into the system. So we have a daily report or a monthly report that in which numbers can be entered in for each site, for each indicator of interest that we don't actually capture on the patient level. It's just stored in a separate table. This is in our legacy system. So the reason I bring it up is because there was a Summer of Code project this past summer, which I was mentoring, which was, well, it aimed to bring the same functionality as a module to OpenMRS. So that will then be exposed as a data set potentially. So the goal being that you can have both patient-level data stored as much or as little as you need to, as well as an ability to enter aggregate data on a periodic level, and then take both of those data sets together and output them to one report that you may need to submit to the Ministry of Health. And we could export that in a common standard like IXF or SDMX. What we do in Haiti at the moment is we output it to a predefined Excel template that's given to us, and it's submitted in Excel. And I think Darius is going to demonstrate how we put that together so far this afternoon.
You're missing somebody around here. If I shout loudly, you'll realize. Are we meant to finish at 3? 3:30. Okay. I think it's 3. I think there's another hour of sessions due to start now.
Thanks very much for your appreciate that.
I think we may
Sorry about that. Yeah. I think there was just one last time, which is who owns the data. So does anyone want to speak to that point?
Me.
Yep. Who owns the data?
Huh? I said me.
You want to? Oh, you own the data. No. Okay, who does the data own to? Who has any experience in defining that? Correct.
In Australia, it took us 7 years for the government and the legal framework, and the data belong to the patient. And basically, they don't even describe patient. The data within the healthcare facility belong to the person acquiring healthcare services. And that was very cultural driven, and that's it. So Australia got 7 different states, therefore we have 7 different legal framework for that, and which it took so long to get a national approach, which is just got approved this year. For the data of that person belong to the person, and they need to get consent, the healthcare professional, if they want to transfer that data, especially in rape cases, psychiatric cases, and they have quite an extensive cases scenario that the Health Informatics of Australia put forward for that.
Thank you. I think when I asked who owns it, maybe ownership wasn't the right verb, although I'm very interested in your answer and what others have to say about it. But I guess what I was thinking more about is who has access to alter this data? And I mean, based on some experience IRC has had in the past, we worked with a project in Uganda on health informatics, and we didn't involve the ministry at all, and then we kind of had our wrists slapped about that. And then we moved to Mozambique with something similar, not exactly the same, and we got involved with the ministry very, very closely, to the point where the servers were being hosted there. And again, it worked in some ways, but it didn't work in other ways. And I guess what I'm asking people here in the room is to know if they have experiences about when and in what way to involve the ministry in developing protocol or practices to access this data and manipulate it somehow or sometimes. But because I think doing that or having the knowledge of who has access to do that, or who has the ability to adds value to what is in there. And I think otherwise ministries can say, well, this is just not true. So I don't know if that's clear, but I'm interested to know what experiences people have had with working at that close level with ministries on data warehouses. Or
Thanks, Shatley. Anyone want to answer Shatley's question? Satoshi?
I think from our experience in India, we have about all the districts in India reporting aggregate data through DHIS. And what we have found out is unless the people from the health staff from the government participate in reporting and they start accepting the application, wherever we have gone and we have tried to collect data for a small period of time, I think it's not worked. Unless we have the ministry's approval and their people doing it, the system itself, which is already established, doing it, it does not sustain. So I think it's most important to involve people who are already in the health department.
Yeah, I'll just try to comment, but in a slightly different context, because this is something we've tried recently. We've just had about 2 years ago, we completed the Kenya AIDS Indicator Survey, which has pretty sensitive, it's survey data, yes, but it's got pretty sensitive, okay, it's de-identified information, but you can still go back down to clusters or districts, which again is something that ethically, perhaps the issues about it. But in terms of access, together with the Ministry of Health, we defined a data access form, which has to be completed. So the data is owned by the government. It's hosted by the Kenya National Bureau of Statistics. But in order for you to access that data, you can't go to any level. So I'm trying to think about that in terms of relating that to the health facilities, that you can't directly go to a health facility and ask for data. But you've got to get the authorization from the national level. So in that data access or data request form, it's got information to do with, one, the purpose of that information. If you want it for, say, research purposes, you've got to attach your protocol that's approved already by the local IRBs. If you want it for programmatic purposes, you still have to indicate that you've cleared through, all the ethical requirements through appropriate IRBs so that you can get access to this data. So this form is now very well accepted by the government, and we're hoping that it's something that we can extend to other areas of where people need to access data at various levels.
Thanks very much. I think we're kind of out of time. I'm just going to answer Chately's question very briefly, just to say that there is definitely a difference between data access, data ownership. But just to talk about ownership that you raised, we came across an interesting case where there was a legal opinion around ownership of the data, strictly ownership, and they drew the distinction between data which was stored on paper records, data which was stored in a compiled database which was stored in a data warehouse, etc., and that the people that had compiled those databases, in fact, in law, were recognized as having rights on that data. So although it's easy to go back and say that the patient owns the data, the ministry owns the data, depending on how the IRBs have been given approval, etc., just through a legal set of eyes, they say that anyone who's invested time and money in compiling data from a clinical record, a paper record, into a database, in fact, has rights on that data. So, probably quite a controversial thing that would take a long time to discuss, but an interesting viewpoint.
Is that only in South Africa?
I would think it would be a universal legal principle that, if you've invested, you would think about it. If you've spent money on compiling data, and we have that at the MRC. We have tons of data which has been collected on food composition database, which is many, many records, and some people in the South African public have tried to access that data. These are analyses that have been done of foodstuffs. They try and access that data under the Freedom of Information Act in South Africa, and they're denied access to it because it's in compiled format. So that's interesting.
With the pharmaceutical databases, there's a different thing because in Chile, particularly, that's in the legal inquiry, pharmaceutical data that the health ministry was collecting, and plus private clinics, they were actually making very dodgy business between that. Therefore, that legal background and who collect the data got the right, maybe not protecting the public good, because that's actually just happened 2 months ago in Chile.
Sorry, since I have this microphone, can I just follow up Chris's point? I think it's a very good argument that you advanced, and I'm just trying to think of routine data. If it's not for research purposes, let's assume that it's just a normal public health facility where they're routinely collecting data for patient care. Not for research. Wouldn't you look at that as an investment? In terms of the government investment, because the healthcare workers that are working there to record all this information from the patients are employed by the government. So by extension, the local health facility owns that information, and to a large extent, the host government.
Yeah, I don't think that's a problem, because that'll be handled by their conditions of service. It's more a case, kind of what worries me, and again, I don't want to say that I support this view, just that we encountered it, really would be where a foreign donor perhaps came in and sponsored the collection of data in a particular facility and compiled it from paper records into an electronic database. One would, by extrapolation from that previous decision, one would say that they would have some rights on that data. And I think even more strongly, where it's a research type funder, and there was an expectation that this data would be used to public research results, then from what we understand is that the courts would uphold that right.
I think that's very exclusive to a few countries, actually, Chris. That's definitely not the case in most European countries. It's definitely not the case in Canada, and it's not the case for most data in the US. I think it's very variable, and it's definitely not as strong protection in the US as in Europe. The NIH funded studies, that data belongs to the public, and anybody can ask for it, and they're required to give it to you by law, and they do. Sometimes they're slow about it. Canada's just passed had a ruling which has required Facebook to delete without trace all of the personal data on anybody who asks to delete it. And because they represent, I think, 12 million out of the 200 million people, Facebook has changed their law internationally. So hopefully that's really improved the situation, that they're not allowed to hang on to that data, and if they don't own it and actually have to delete it. So I think there is a legal framework, especially from Europe, where anybody who collects personal data in a database has got to publish, under the Data Protection Act, they have to publish the fact that that data exists. They have to make a copy available to the individual, and they have to agree to correct it, or in some cases delete that information.
Well, thanks, Hamish. Thanks for that clarification. And I think we're out of time. Thanks very much.